Hello, everybody in podcast land. I'm Dr. Ted Thatchencary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us on MD Roundtable, folks. I'm super excited today. For today's guest is Joseph Zucchi, who is the clinical supervisor and physician associate at Transition Medical Weight Loss in Salem, New Hampshire. He is also an obesity medicine speaker and writer. Through his clinical work, Joe's teaching, writing, and advocacy, he has been committed to advancing evidence-based obesity care and improving long-term health outcomes. Welcome to MD Roundtable, Joe.
Thanks, Ted. Glad to be here. Appreciate the opportunity and looking forward to our discussion today.
Yes, likewise, Joe. Very excited. First off, I always like to start off with a brief journey for the listeners, Joe. How did you get involved with obesity medicine?
Sure. Yeah, it's something I've been passionate about my entire life. Even when I was a teenager, I was into personal training and kind of helping patients through fitness and nutrition guidance to just see the benefits of exercise and nutrition on health and helping patients on their weight loss journey. I eventually went on to become a fitness and nutritional advisor at a medical weight loss center and really became passionate for how we can help patients to prevent so many comorbidities and, to not just treat them, but prevent them from the future from happening. And so it was really rewarding to see how much power there is in obesity medicine and lifestyle changes alongside, of course, the education that we try to provide to patients. Then I went to get my master's, become a PA. Even during my rotations, I would choose obesity medicine as my electives, and really was something I was just excited to get into. And right after finishing up my, even prior to going to PA school, I actually worked at Tufts in Boston and did research on nutrition and exercise physiology. So something I've been really, truly passionate about. Right after getting my PA degree, I actually worked at Transition Medical Weight Loss, where I work currently. So for the past going on over 70 years now, I've been the clinical supervisor at Transition Medical Weight Loss, and we have a really comprehensive program, and we try to help patients with nutrition, exercise, medication, lifestyle changes, behavioral modifications, and it's very rewarding for us. We have over 50,000 pounds of weight loss over the years. We have a dietitian, a nurse practitioner. We create workout plans for patients. We have a lab on site. We do body composition analysis. We actually have a full healthy food store in our office to provide patients structured meal options. And so it's something that is truly rewarding day in and day out to help patients on their weight loss journey and hopefully improve their health. So in addition to that, I've become very passionate about advocacy in terms of fighting for coverage for obesity medications. I often do podcasts, op-eds. I'm on the board of the New England Obesity Society, so trying to just do my part to spread, hopefully, knowledge and education for both patients and providers in this space.
That's wonderful, Joe. Yeah, that's quite a background you have there in obesity medicine. And it sounds like Transition Medical Weight Loss Center it's one of the premier weight loss centers across the country, right?
It is very unique. Yeah, I'd like to think we have one of the most comprehensive multidisciplinary programs out there. We won Best of New Hampshire for the past 3 years and truly, try to help patients. We do monthly support groups here. We offer both telemedicine and in-person visits. We even have a full online portal that gives patients the ability to monitor nutrition, get recipes, message us for advice. So we really try to help patients. We have a lot of structure here. We often see patients either weekly or biweekly or perhaps monthly, but the more support we can provide, the better the outcomes lead to. And so over the years, we've had some truly amazing transformations, but beyond just the weight loss is helping patients improve blood sugar, blood pressure, cholesterol, sleep apnea, osteoarthritis, fatty liver disease. The list goes on, right? There are 200 comorbidities that are tied in some relationship to obesity. Mm-hmm. And so we treat upstream when we help patients with obesity, and we prevent the many, many downstream effects. And what we try to do here is really help patients on that whole journey.
Fantastic, Joe. And if potential client wants to reach out to you, they can reach out even if they're out of state?
Yeah, so I'm licensed, and our nurse practitioner and our dietitian are licensed in Massachusetts and New Hampshire. And so for anyone in this area, certainly happy to help either in person or online. Our website's transitionsalem.com. But there are certainly many obesity medicine providers across the country. So if anyone is in need of help, certainly, hopefully you can find a teammate to help you on the journey.
Great. Well, switching gears for our listeners, Joe, can you explain what are GLP-1s in simple terms?
Sure. So when we think about GLP-1s, this class of medications actually came out first in 2005. And so Byetta was one of the first GLP-1 medications, and it was originally approved for diabetes. It was a daily injection. And over the years, there's been a lot of advancements in research and evolution of this class. And it's quite exciting. It's become somewhat of the gold standard now for obesity and for diabetes. And this GLP-1 is a natural hormone that our body makes, glucagon-like peptide 1, and it's basically an incretin hormone that is released by our intestinal cells. And after eating, we get this somewhat of an uptick in GLP-1, especially after eating things like protein. And it helps to have some benefit on blood sugar regulation, stimulating the pancreas to release more insulin. It also does signal to the brain satiety and fullness. And so there's many different things there. But unfortunately, our natural GLP-1 has a very short half-life of only a few minutes. It is broken down by the DPP4 enzyme quite quickly. And so GLP-1 naturally doesn't really have a prolonged benefit for most people. And so although having a proper lifestyle and nutrition habits can potentially boost it, it pales in comparison to what these medications can achieve. And so when you look at the evolution of GLP-1s, the first one that became approved for obesity was Saxenda back in around 2015. That was liraglutide, also known as Victoza for diabetes patients. That was a daily injection. That achieved some success, about 7 to 8% weight loss, which was significant at the time. And then we have the biggest kind of evolution was when Ozempic came out for diabetes. That became a semaglutide is the ingredient. That was a weekly injection and showed further benefits on A1C reduction for diabetes, but also further weight loss. And that's why it eventually became approved for obesity under the name Wegovy. And so that is made a big difference because now we're seeing 15, 16% weight loss in a once a week injection. So easier for patients, better outcomes. And we'll talk about the other benefits that have been now proven in terms of cardiovascular risk reduction and so forth. But GLP-1s, semaglutide honestly is 94% bioidentical to your endogenous GLP-1, but it's tweaked in just a slight amount to, for one, help to not get broken down by that DPP4 enzyme. So you have much longer half-life, achieving basically a week-long half-life. The second thing is it has much stronger binding to albumin, so it can linger around in the bloodstream, and certainly higher potency, so it's able to reach the appetite regions in our brain to really stimulate the satiety effect. And so in general, these medications reduce hunger, reduce cravings. A lot of patients talk about less food noise. There's also a slowing of digestive emptying, so our gastric emptying is delayed a bit, so food stays in our stomach longer. Again, it does stimulate insulin when the blood sugar is high to help keep it in normal range. So it has a blood sugar benefit. And it's exciting to see, again, some patients reporting anti-inflammatory benefits, and it leads to cardiometabolic health improvements in lab work. So that's the general overview of GLP-1s, but it's also evolved even further. Tirzepatide is kind of the next exciting iteration that became approved first as Mounjaro for diabetes, and then now as Zepbound for obesity. And tirzepatide is not just a GLP-1, but also targets GIP, which is another incretin hormone that has a satiety benefit. And Mounjaro and Zepbound actually are based upon the GIP backbone, but it also can target GLP-1. So you're getting a little bit of a synergistic effect. And by hitting two hormones, it helps in terms of a bit more weight loss. We're seeing up to 22% weight loss with Zepbound. I will mention Wegovy now has a higher dose, actually, Wegovy HD, which is 7.2 milligrams of semaglutide that is now achieving over 20% weight loss. So we do have both medications now reaching 20+% weight loss on average, which is pretty exciting, and more to come as well.
Yeah, no, thanks for sharing that. Very exciting to see the progress of these medications, Joe. How long have the oral versions been out?
Yeah, so it's exciting to now have oral options for patients. So the reason that traditionally these medications have been injected is GLP-1 is a peptide, and it's a long strain of amino acids. And if we were to just take these typically orally, our stomach would degrade it and break it down and kind of denature the protein, and it wouldn't have any structure or shape. So anything that gets absorbed would not have any physiological benefit. And so because of that, these medications have traditionally been injections, which bypass digestion, get a lot, much better absorption that way. So what was unique is a few years back, Rybelsus was the first diabetes GLP-1 pill made from Novo Nordisk, which is semaglutide, just like Wegovy and Ozempic, but in a pill version. And what they did to make Rybelsus absorbable is first they had to make the dose higher to make up for the fact that it doesn't get absorbed well orally. In fact, the bioavailability is only about 1%, so a lot lower with the pill, but the dose was higher to make up for that. Mm-hmm. And the unique thing that Novo Nordisk created was something called the snack mechanism, where it actually has an ingredient in there that buffers the acidity in the stomach wall and allows GLP-1s to get absorbed through the gastric lining. And so very fancy, but it does need to be taken first thing in the morning on an empty stomach, and patients have to wait half an hour before having food or medications or beverages to allow that absorption to occur. And so Rybelsus was a good kind of start, although the efficacy was a little bit less than the injectables. But there was a reformulation and a slightly change in the dosing, and now we have oral Wegovy. And this new version, which just was approved in January, is actually showcasing equal weight loss to the injection, around 16%, which is exciting. Wow. And so the dosing of the pill is higher than the injection, and it is a daily pill versus a weekly shot. But it is nice to now offer patients the option of both injectable Wegovy or oral Wegovy with weight loss surpassing 15% and proven benefit on cardiovascular risk reduction. And so that is unique about Wegovy and the pill version. Then to add to that, we now have a second oral GLP-1 that is approved just this past month called Foundeo. This is made by Eli Lilly, and this is a different molecule. This is called orforglipron, and this is the first ever non-peptide GLP-1 receptor agonist. And so this medication was designed inherently to be taken orally. It has a high bioavailability of over 77%. And orforglipron is nice in the sense that it can be taken at any time of day, regardless of with or without food. There are no food or water restrictions. And so it creates a little bit more flexibility for patients. It is a new molecule, but it did get FDA approved through its different trials. And the weight loss is showing up to around 13% on average. So a little bit less than oral Wegovy, but it's close. And so we now have two options that are FDA approved for obesity that are oral options alongside the previous injectables.
That's amazing. Yeah, you make a great point because, a lot of the so-called options that are available for patients online, there's thousands, right, that people can shop for online. And, a lot of these come from these compound pharmacies.
Sure.
So you mentioned that like Novo makes that snack molecule, right?
Yes. Yep.
And I think that's a great point to make because a lot of people probably don't realize that a lot of the drugs, medications they're getting online probably don't even work, correct?
Exactly. Yeah. It's, unfortunate. Of course, it is sad that the costs and access and coverage has been a barrier for many patients. And I understand that. But at the same time, going to the gray market and buying knockoff versions of compounded medications is a risk. It's a safety risk. It's a health risk. These are not FDA approved medications if you're not getting the medication, from the brand that manufactured it and created it. And just like we talked about, the pill versions of these medications are not normally well absorbed and they require fancy design to get absorbed. So any patches or pills or drops that are being sold that claim to be, GLP-1s are likely not going to be doing much at all. And you're also risking with safety because it hasn't been vetted by the FDA for purity and safety. Mm-hmm. And so the reason compounds even became available for GLP-1s was because there was a shortage of Wegovy and Zepbound a few years ago just due to the demand. Mm-hmm. And even though these medications are patented, there's some rules that allow for manufacturing of compounded versions when there is a time of shortage. And so due to that, a lot of companies started to proliferate these kind of third-party versions of the medications. But that it unfortunately became just a race towards, marketing to try to sell these medications for profit. And so now all these different places were selling these and sometimes even at higher prices than the actual brand name medication. Yeah. And the shortages are no longer in place. These medications have been well in stock now for several years. Everything is good in supply. And so compounding has been this, the FDA is starting to step in now and trying to kind of shut down or advise against compounds because of the fact that they are technically not legal to be made at this point. And sometimes they try to get around the laws by combining it with B12 or mixing it with something else to call it unique or, different. But at the end of the day, again, I understand patients are being proactive about their health. I'm all for, utilizing a tool that can be helpful. Mm-hmm. But this is your health that's at play here. You want to make sure you're using a medication that your provider has, determined is the right fit for you and is the right dose for you, and has been safely tested through all the different rigorous trials to prove that the potency and the purity is correct.
Yeah. Yeah, thank you. Thanks for clarifying that.
Mhm.
So, why might someone consider the oral version of the semaglutides versus the injectables, Joe? Like, who's a good candidate for the oral version?
Yeah, it's a great question. I think it's always good to have options. We're getting to a place where we have now more personalized medicine, where we can hopefully, cater the medication to the patient versus a one size fits all kind of philosophy. When we look at the options that are oral now, a couple benefits. First, if somebody does not like injections, this is a great option. Now they don't have to worry about any more needles. I will say, initially, patients were a little bit apprehensive to do injectables, but once they saw how easy the auto injector pens are from Zepbound and from Wegovy, many times the needle phobia kind of disappeared once we coached patients through it. The real pens are, kind of very easy to use with a push of a button. So that makes it simple.
Hmm.
But for some, still the idea of a pill is just more comfortable for them. So that's great. The second benefit of the pill is it is a little bit cheaper for those that don't have coverage. The cash price for Wegovy pill and Foundayo pill are currently the lowest prices for patients.
Hmm.
And so that gives people a little bit of a discount there for those that are paying out of pocket. Third thing, I think for some patients, the idea of a pill just kind of almost, even though injectables are not, intensive therapy, for some people they think of injectables as like a higher grade of kind of health need, and having a pill option is perhaps a more lower barrier to entry. It maybe is a little more comfortable for people to think about starting their weight loss journey with the help of a pill, and so that may help patients to be more comfortable with that concept. And then also, there's some patients that maybe use the injectables, but for maintenance purposes, the pill is adequate for them, and they may find the pill to be a good option for that, just to help preserve their weight loss.
Hmm.
And that kind of gets into the topic of why medication is often necessary for treating obesity. Unfortunately, back in the day, and sometimes there's still a lot of stigma and bias in our field, that patients are told that they just need to try harder with their diet and exercise, and that they don't have enough willpower, and that they're kind of chastised for their failure to lose weight. But that's sad, because we need to give compassionate care to our patients and understand that obesity is truly a chronic, complex, relapsing, progressive disease state. And this is not a lack of willpower. This is biologically driven. When we gain weight, our body does not like to lose weight. It sees weight loss as a survival threat. And when it sees weight loss happening, it compensates by increasing hunger hormones, by decreasing fullness hormones, by slowing down our resting metabolism. And so when you combine that neurobehavioral aspect, which is hormonally driven, with the fact that we have a very challenging food environment today, we are constantly surrounded by easy access to large portions of processed foods. We have very stressful jobs. We have very sedentary jobs. Many patients may have different health conditions that could be impacting them. Medications can sometimes be weight gain promoting.
Hmm.
People have sleep deprivation, stress, all these things. Certainly, even genetics plays a big role here into why patients are more prone to having obesity. And so we should never chastise somebody for using a medication. It is a tool in the toolkit to help them, not in place of the lifestyle, but alongside it. And just like if somebody has hypertension or high cholesterol, we would never say, you got to try harder with lifestyle before I give you lisinopril. That would be considered crazy, right?
Yeah.
But medications for obesity should be thought of as the same way. We, of course, want to help them with the lifestyle changes, but oftentimes the medications can enable the lifestyle changes to be easier, because they're no longer fighting appetite dysregulation. They're no longer fighting the food noise, and they feel more satisfied, and they often become healthier, and they make better food choices, and they become more active. And so I hope that, for anyone that is perhaps new to obesity medicine, for any patients that are thinking about a medication, don't be thinking of this as a cop-out or a crutch. It is a tool that warrants,
Hmm.
potential discussion with your provider, just like any other medication for a chronic disease.
Great. Yeah, thank you, Joe. And based on the oral version show, like what is well, actually you had mentioned the efficacy of like Wegovy is pretty comparable with the pill versus the injectable, right?
Yep.
Okay.
Yeah, so if we go by the big four, so we have Zepbound still currently leads in terms of most weight loss, the highest dose averaging around 22.5% weight loss. The second would now be Wegovy injectable, and the new version, there's a now 7.2 milligram Wegovy HD that's achieving over 20% weight loss. Prior to that, the Wegovy injection maxed out around an average of 16% weight loss, and the pill matched that. So oral Wegovy is equal in efficacy to the kind of 2.4 milligram injectable Wegovy. So that's great. And then Foundayo is just a little bit lower at that 13% weight loss. But again, nice to have options for people. We now have more tools. Not everyone needs the highest or most amount of weight loss. If somebody's looking to lose, 25 pounds or less, then or has a lower BMI to begin with, then maybe the Foundayo option or oral Wegovy is perfect for them. But if somebody has a BMI over 35 or 40, then perhaps,
Hmm.
Zepbound or Wegovy HD will be the right fit. But any medication can be beneficial, and those are averages. We've had patients, actually yesterday, we just had our highest ever weight loss recorded. Our patient just surpassed 220 pounds of weight loss. She now has lost more than she currently weighs.
Wow.
And so truly anything is possible. And she lost 50% of her body weight. So there are hyper responders who exceed the averages. There are some, of course, that go below the averages. But when done alongside the lifestyle changes, anything is truly possible.
Yeah. And what are some of the downstream benefits? Like, I know a lot of these medications you had mentioned
Hmm.
have other benefits besides weight loss, right? Like, for
Yeah,
example, you mentioned precision medicine, right? So, like,
sure.
not everyone is the same, right? Because, like, the Southeast Asian community, which I'm part of, you know, our metabolic makeup is totally different, right? So,
Hmm.
like a lot of these some of these medications have an indication for MASH, right, which
Yep.
is metabolic associated steatohepatitis.
Correct.
You've seen cardiovascular benefits, et cetera. Can you talk about that?
Sure. Yeah. So it's exciting. We have just kind of more preliminary things that we can talk about, as well as FDA approved indications. So Wegovy is FDA approved for reducing the risk of cardiovascular disease in patients with a history of cardiovascular disease. So basically, those that had a previous heart attack or stroke, they did a trial, they showed there was a 20% reduction in cardiovascular disease if they're on Wegovy. And that was actually shown even prior to a lot of weight loss being achieved. And so there's clearly some benefit to the medication inherently on cardiovascular health. That's exciting. And then, like you said, now Wegovy is also approved for MASH, which is a more of an advanced stage of fatty liver disease. And so that is exciting as a tool that can be helpful as well. Zepbound is the first ever medication approved for obstructive sleep apnea. It is approved for moderate to severe OSA in patients with obesity. And so that was shown in their Surmount OSA trials, where they actually showed a average of a 50 to 60% drop in their apnea hypopnea index. And that led to, at the end of the trial, half of the patients had achieved disease resolution. So powerful improvements in OSA there. And so those are two big benefits, or three big benefits that are actually on the label. But if you go outside of that, certainly we know these medications are approved for type 2 diabetes. And so great improvements in A1C. In the trials for both Wegovy, Zepbound, and Foundayo, we have seen improvements in cardiometabolic health, reductions in blood pressure, cholesterol, triglycerides by up to 25%. And that translates to certainly better health in general. We've had patients that have PCOS or the now PMOS. We have arthritis reduction. Part of that, again, is reducing just the pressure on the joints due to the weight loss. But part of it is the fact that there's some anti-inflammatory mechanisms here. And people report even before they lose a significant amount of weight that their joints feel better. So there's that exciting part. And there's even a trial yesterday showing maybe even reduced risk of cancers or cancer progression.
I
Certainly
saw
these
that.
benefits, yeah, have been shown on chronic kidney disease. Truly, like we said, there are 200 comorbidities that are tied to obesity, and many of which of those will likely improve with the help of these medications along the way.
Yeah, that's amazing, just what we're seeing with these drugs.
Yeah,
So having said that, Joseph, what are some of the common side effects that a patient might experience?
sure. Yeah, like with anything, everything is a pros and cons and a discussion with your provider to determine if it's the right fit for you. I'd say for most patients, these medications are generally well tolerated. Symptoms that are most common are mild to moderate GI symptoms. And so the number one side effect that can occur is typically nausea. And for many people, this is not, truly vomiting. This is often a little bit of queasiness, perhaps if they overeat in too big of a portion. If they have a meal that's higher in fat, that can lead to a more delayed gastric emptying and also cause more nausea. So those are some possibilities. For some, it can lead to constipation or diarrhea. Those are the things that, again, for many people are mild and often dissipate over time as their body gets more acclimated to it. There are 6 dosages of Zepbound, for example, and again, multiple 5, 6s of the others as well. So that allows us to titrate dosing accordingly. If somebody is doing well on a given dose, we can certainly maintain there. If somebody's having side effects, we can stay at that dose. Or if somebody is plateauing and having no side effects, we can increase their dose. And so a lot of room for flexibility. So it's not one size fits all. The dose escalation will vary dramatically from person to person based on their progress and how they're doing. outside of the GI symptoms, which often do kind of dissipate, there are other things to be mindful of. One thing that I'll talk about that's on the label of all of these is the boxed warning for medullary thyroid cancer. I will say, just to provide some context there, in trials for GLP-1s dating back to the beginning, they did show in rat studies there was a potential dose-dependent increase in thyroid C-cell tumors. The good news is no human trials have shown an increased risk or a signal there. And when you look at the anatomy, mice and rodents have a lot of GLP-1 expression on their thyroid, and humans do not. And so due to that, it is certainly still on the label, and it is contraindicated in patients with a personal or family history of medullary thyroid cancer to use this, or anyone that has multiple endocrine neoplasia syndrome type 2. But outside of those very rare things, and again, the data is reassuring that that is likely more of a rat issue than a human issue due to the kind of physiology there. I would say that it's rare that we have to, not utilize it because of that. Other things that can happen, certainly when people lose a lot of weight, they can have gallstones and gallbladder issues. That can occur through lifestyle, through medication, or through bariatric surgery, especially those that are losing a significant amount of weight or those that are losing weight more rapidly. And so nothing that the medication isn't causing inherently, it's more so just that these medications are helping more people achieve weight loss. And so we try to be mindful of moderate, healthy weight loss, and certainly gallstones can occur with any weight loss endeavor. Pancreatitis is also on the label of these things. Again, we have to take into account all the different factors. If somebody has a history of multiple episodes of pancreatitis, that's something to have on our radar. But for most patients, the risk is very low. The Zepbound trial actually had 0.2% of patients in the trial on Zepbound had pancreatitis, and then the placebo group had 0.2%. So a low signal of concern, but something just to be mindful of that has been shown in the literature. Outside of that, that's kind of targets the major things. There are some patients that can have some episodes of reflux or fatigue. These are things that we can work through with lifestyle changes oftentimes. There is a common concern in the news and the headlines about muscle loss, and I'll say that is a bit overblown. When you look at the trials from the companies, they actually did DEXA scans before and after their weight loss, and they saw that the majority of the weight loss came off as fat mass, and a minority as muscle mass. About 3/4 of the weight tends to come off as fat mass, and less than 1/4 as lean mass. And we have to keep in mind that lean mass also includes water weight and organ weight, not just muscle protein tissue. And so I do always encourage patients to make sure they're getting adequate protein and exercising to further mitigate muscle loss. But I do think that it is a bit overblown that muscle loss is a major concern for most patients. Again, we want to be mindful of our population. If we're treating a patient that's a bit more older or frail, let's be more gentle on our dose escalation. We're not trying to reduce appetite to nothing here. We still want to fuel our patients with proper nutrition, right, but hopefully we can monitor them and make sure they're making the best health outcomes.
Sure, yeah. I'm glad you brought up the muscle mass because I think that's also related to how much weight loss you have, right? Because
exactly. It could happen in any weight loss endeavor.
And how important is strength training?
That's a very important. It's something that, again, it's dear to my heart as a background in personal training and something that I promote with all of my patients. But yeah, I try to meet people where they're at. Certainly if they're new to exercise, let's start with just increasing our step count. Let's get in some more movement and some walks. If somebody is able to, I'd love for them to do some strength training, and a little goes a long way. If people could work out even just twice a week with some full body workouts, body weight, dumbbells, bands, if they have a gym membership, I even create them a workout plan if they'd like. But it really helps. As great as protein is exercise far exceeds it in terms of benefits on preventing muscle loss. And it has benefits on bone density as well. We want to prevent osteoporosis down the road. And so I would definitely encourage patients to try to incorporate some strength training a few times a week to support them on their weight loss journey, not only because of strength and just muscle itself and body composition, which is important, but also the fact that muscle is a major source of our resting metabolism. The more muscle we have, the more calories our body is burning 24/7. And so by maintaining muscle during any weight loss effort, it'll help us to have better success at keeping the weight off because muscle is metabolism. And so we really want to encourage patients to make sure that it's not about rapid weight loss. It's about healthy weight loss, maintaining the best body composition, getting adequate nutrition, protein, fiber, water intake. Those are huge. We don't want people to become dehydrated. But again, exercise is a big part of that too.
Very important points, Joe. Thank you. Joe, and this is a very rare complication, but do you want to just talk about like the aspiration risk when someone's undergoing twilight anesthesia or general anesthesia?
Sure. Yeah, great topic. So it is on the label of these medications that we want to be mindful if any patient is undergoing anesthesia. Certainly, if it's elective, then we can plan ahead for this. But if it is more last minute emergency surgery, there's less control over that. But the reason this is on the label is that GLP-1s inherently do delay gastric emptying. And so if you think of it, if we have food that's still in our stomach and it hasn't been digested and passed along yet, then that could increase the risk of aspiration during anesthesia. If there's any food left over, that could be a concern. So I will say a few things. In a perfect scenario, it's debatable in terms of the protocol. It varies from practice to practice. There's no standardized guideline. Different anesthesia associations have come out with different recommendations over the years. The more common thing that you often see is a recommendation from the surgeon or the anesthesiologist to withhold the GLP-1 medication 1 week prior to planned surgery, or even anything that involves anesthesia, even a colonoscopy, just to reduce that chance of delayed gastric emptying impacting aspiration risk. And so that's a common strategy that works generally fine. There's some more recent literature that says you may not even need to withhold the medication, just have the patient do a prolonged fast. Maybe the day before they're just doing liquids only instead of food. And that could be a way to allow them to sustain therapy versus stopping and starting again.
Yeah.
If you're off it for just a week, probably not a big deal. But if somebody is off the medication for more than 2 weeks, they may require a dose de-escalation when they restart the medication because of GI side effects could occur if their body's not kind of acclimated to it. So that's the concern if somebody's off it for too long. I will mention, too, that the delay in gastric emptying actually dissipates over time. It was shown in the trials to be highest at initiation and at dose escalation. If somebody eventually reaches a dose and stays on that dose for quite a while and many months down the road, the gastric emptying time actually resumes basically normal. And so they did this in trials where they looked at Tylenol absorption, and they looked at starting the medication and later on, and they saw the differences in absorption time there. And so if a patient is on either a lower dose or perhaps been on that dose for a while, I have even less worry that there's aspiration risk. But if somebody is having GI symptoms or up titrating their dose, then they do want to be more cautious about making sure they are not, having surgery too close to that increase in dose. I will also mention that it also depends on what they've been eating. If somebody has surgery the next day and it's planned, and the night before, because they knew they were going to have to fast, they had a massive dinner, that has a higher risk of still being in their stomach and still could be digesting, and that could lead to a higher risk of aspiration. And so trying to counsel patients that the day prior, probably having smaller, lighter, gentler meals, maybe more liquids, is a safer bet just to reduce the risk of aspiration.
Yeah. 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 So I guess bottom line, just, if you're undergoing a procedure like a colonoscopy or elective surgery, make sure you talk to your primary care doctor, talk to your anesthesiologist.
Exactly.
Great. And Joe, here's a kind of common question. Can someone switch from injectable Wegovy over to the pill version if they're on it?
They can. Yep. It is doable to switch from any GLP-1 to another GLP-1, but that one there is actually the easiest because oral Wegovy and injectable Wegovy are both semaglutide. So the switch is direct and easy. If somebody is actually on the 2.4 injectable Wegovy and doing that once a week, they can start the 25 milligram top dose of the pill 1 week after their last injection, and vice versa. If somebody is on the pill, they can start, and they're on the 25 milligrams, they can start the injectable 2.4 the next day. And so that is an easy switch. If somebody is changing from one molecule to a different molecule, we often do, it's a bit more kind of a fine art of figuring out the dose, but we do often, start a little bit lower. Like if somebody's on the highest dose of Wegovy, we wouldn't necessarily go to the highest dose of Zepbound right away. We'd probably start somewhere in the middle and then up titrate from there as needed. So we just, because it is a different molecule, there's a chance of a bit more side effects adjusting there. But it's rare that we would have to start somebody over at the lowest dose if they are on a higher dose of a different medication and are switching. But it is nice to have that option. There was a recent trial that's kind of pre-published called Attain Maintain, where they had patients switching from Zepbound or Wegovy injectable to Foundayo, and they had them start at the 9 milligram dose and then titrate up from there. So we have a little bit of data to go by, but it's up to the provider and the patient to determine, the right potency and the right dose and how they've been tolerating it. But generally, it is definitely doable.
Great. And Joe, who would not be a good candidate for the oral version of these medications?
Yeah. So again, the contraindications to the class in general would be the personal or family history of medullary thyroid cancer. If somebody has a severe gastroparesis, likely not a good candidate for these medications because that delays gastric emptying. If patients have a history of developing perhaps pancreatitis on a GLP-1, it may be worth being a little bit more mindful of that. But outside of that, or certainly any allergic reaction to a previous GLP-1, most patients could be a good candidate. I would say the oral options are generally fine for everyone except for those that have had any stomach surgery. If somebody has had gastric bypass or gastric sleeve, we know we've altered the anatomy of the stomach tract here, and there's no data or trials to show if oral Wegovy will be absorbed or if Foundayo will be absorbed well. We can assume that oral Wegovy probably is definitely not a good fit for those that have had any bariatric surgery because it needs to get absorbed through the gastric lining. And if that has been impaired or impacted, we'd hate for somebody to be wasting money and medication if it's not going to do its job. And so I would recommend the injectables for patients that have had that. Foundayo potentially could be an option for those that have had bariatric surgery because it is absorbed in the intestines, more like a traditional medication. But again, if somebody had a bypass, there is some intestinal bypassing occurring there, so we still don't know the absorption there. So injectables are probably still best for those that have had any previous GI surgeries, especially upper GI.
Great. Thanks for clarifying that. And how important is it, Joe, to have a collaborative approach, such as seeing an obesity medicine specialist, a nutritionist, even your primary care doc being involved?
Yeah, it's vital. It's vital. And again, it's unfortunate with some of these compounds when patients are just getting this stuff shipped to their door and there's no supervision, there's no counseling involved. We're blessed here to be able to see patients on a very consistent basis, either weekly, biweekly, or monthly. But for those that are only able to see their provider every few months or, even 6 months or once a year, it's still so important to keep tabs and connect with your provider, touch base with them, and hopefully meet with them, as well as hopefully meeting with a more well-rounded care team, be it personal trainer, a registered dietitian, a counselor, because this is a complex multifactorial disease state. And especially with your provider when it comes to dosing and escalation, if somebody is on a low dose and never increases their dose and they're plateauing, then it may just warrant, a dose escalation. If somebody's having side effects, then let's coach you through how we can reduce those side effects, either through changing medication or dosage or dietary changes. And so it's just vital to make sure that you're touching base with your provider, getting those little adjustments. There is such great benefit to these medications, but they still are primarily appetite suppressants. And so the habits still need to be, changing over time. The lifestyle, the nutrition, the exercise is still what leads to the progress. These medications enable the lifestyle to become easier, but proper nutrition intake, balanced meals, certainly not skipping meals and just going the whole day without eating is not the goal, but portions, prioritizing our protein and plants and hopefully getting adequate hydration throughout the day. All these things are vital. And of course, exercise as well. So I encourage those that are getting good care to continue to check in with their provider. And for those that, if they're not getting good care or just getting this from some online pill mill, I hope that you can perhaps connect with a obesity medicine provider who's more specialized in this field, because this is something we do day in and day out, can really help you with the nuances to help you get the best progress.
Yeah, very important point you make there. And Joe, is there anything else that's excites you right now in the field of obesity medicine? Anything specific?
Yeah, it's such an exciting field, and when 10 years ago in this field, it was like small changes happening over the course of years. And now it seems like every day or every week, there's a new trial, a new phase 3 publication, a new exciting announcement. So it's such a great time. And of course, exciting to have more tools for us to help our patients with, but also exciting to see patients benefiting from these. And so a couple different things that are exciting. I would say first, just to preclude this, is the fact that there are many other medications that are also approved for weight loss besides GLP-1s. And I don't want to overlook them because they're still a tool that work well for some patients. That dates back to older medications like phentermine, Qsymia. Qsymia is phentermine combined with topiramate. It is approved for chronic obesity, usage. Contrave is also approved. Contrave is bupropion and naltrexone. And both of these medications, work differently than GLP-1s, but also have shown significant, benefit, a little bit less, certainly weight loss than GLP-1s, but in the right patient can work well. Qsymia has been shown 10 to 12% weight loss. Contrave, a little bit lower, 5 to 8% weight loss. But for emotional eaters, that could be a good fit for them. Orlistat is an older medication. It's a lipase inhibitor that prevents the breakdown of dietary fats. not use that frequently. It is over the counter now as Ally. But again, there's different tools for different patients. Some patients may occasionally be on metformin to help with insulin resistance. So keep in mind, it's a broad option base for sure. But I will say, of course, this class of GLP-1 medications is extremely exciting. It's the most efficacious tools we've ever had. And the pipeline is incredible. There are over 10 or plus different medications that will likely be coming out within the next 3 to 4 years that will be approved for obesity, that will give us even more tools. I put together a post on my LinkedIn showing an infographic of the 10 to watch. There's even more than that, but there are a lot of medications that are in phase 3 trial right now showing even more weight loss. One of the ones that just got published yesterday was retatrutide, which is a triple agonist from Eli Lilly that targets GLP-1 and GIP just like Zepbound, but also targets glucagon. And now we're seeing, again, over 30% weight loss in their trials, which is just absolutely mind-blowing considering what we had in the past. And so there's a tool. We also have other medications that are going to be coming out that are targeting amylin. Eloralintide is a medication from Lilly that is showing maybe 20% weight loss, and that is an amylin peptide. So amylin is not a GLP-1. It wouldn't have the boxed warning for medullary thyroid cancer, maybe better tolerated from a GI perspective for those that are prone to more nausea. That's exciting. Novo has a medication coming soon called CagriSema that combines semaglutide, which we have now as Wegovy, with cagrilintide, which is an amylin. And so that combination will be exciting. They also have another medication called amycretin that combines it into one molecule that targets those two things. There are other companies coming out with survodutide coming out, which targets glucagon and GLP-1. Amgen has a medication called Maritide that actually is a GLP-1 receptor agonist and a GIP antagonist, which is very interesting. But that could be a once-a-month injection.
Wow.
And so there is really quite a pipeline of options coming out. Zealand Pharma, Amgen, Boehringer Ingelheim, alongside Novo Nordisk, Eli Lilly, Pfizer, and beyond. And so the pipeline is exciting in our field. We will hopefully have more personalized options for patients, more tools in our toolkit, and more ability to find the right fit for each person. If somebody has more perhaps MASH liver fat, then they may benefit from that glucagon agonism, which seems to really help with reducing visceral fat and liver fat. If somebody cannot tolerate GLP-1s, then maybe the GIP component will be helpful, because Zepbound has been shown to have less nausea, partially because of the GIP agonism that it has. And so amylin may be a good option for those as well. So great options there. And I said the other very exciting thing is that starting July 1st, we will actually have Medicare coverage beginning for obesity medications. This is the first in history.
Oh, wow.
This dates back to, unfortunately, when Part D plans began back in, I think, 2003. There was kind of a law written that any medications used for weight loss or anorexic weight loss medications, poor terminology for sure, but they were considered disqualified from being used on Part D plans. And so all along, we've been unable to get coverage for these for Medicare patients, unfortunately. And I think at the time, obesity was considered a lifestyle problem, a lack of willpower. It was, the stigma of patients are not trying hard enough. And the medications we had at the time were more stimulant-based medications. And so it didn't maybe warrant coverage. But now we understand obesity as a chronic disease that's biologically driven. And now we understand that these medications are life-changing for patients and improve outcomes in terms of morbidity and mortality. And so coverage starting in July will be exciting. This is called the Bridge Program. It's basically running through the government. It's like more of a demonstration program that is going to run from July 1st, 2026 until December 31st, 2027. During that time frame, everyone who has either a Part D plan or Medicare Advantage plan will be eligible if they meet the following criteria. It'll be for patients that have a BMI over 35, no comorbidities, a BMI over 30 with either heart failure with preserved ejection fraction, chronic kidney disease, stage 3A or higher, or also patients that have uncontrolled hypertension after trying at least 2 medications. And then the last group, which is very exciting, is patients that have a BMI over 27 with prediabetes, which is a big group of classification there, as well as patients with a BMI over 27 that have a previous history of heart attack or stroke or symptomatic peripheral artery disease. Those are the criteria to kind of qualify for the GLP-1 coverage. This coverage will be available for Zepbound, QuickPen, which is their kind of new auto-injector that has 1 pen for the whole month in there. It'll be covered for Foundeo, as well as the Wegovy pill and the Wegovy injection, including the new Wegovy HD.
Wow.
And so this is super exciting. Patients will have just a $50 copay, And the government has basically negotiated with the manufacturers to they will be paying about $245 per month for the medication. So we hope that this leads to better coverage down the road for other plans as well, because coverage, unfortunately, has been going backwards in our country, with commercial plans pulling back coverage due to the costs and the demand rise. And so I hope we see coverage get better, because these deserve to have coverage, and hopefully the pricing can make it all work. After this bridge program ends at the end of next year, there will be transition into this balance model, which will require Part D plans to opt into. So we pray and hope that the insurances will keep this coverage going once it starts, because I'm sure a lot of patients will begin benefiting from it. And so, yeah, between medications, the pipeline, and Medicare access starting soon, the field is very exciting.
Yeah, very exciting times ahead, Joe. That's going to cover millions of people, so that's great.
Yeah, I think I've heard about 14 million people will become eligible once this begins.
Wow. So, Joe, on a lighter note, what are some of your interests outside of work?
Yeah, very passionate about exercise, work out myself. I love strength training. So that's something I do. I actually play tennis as well. So passionate to just keep up with movement in those two methods. Family time with my wife and my daughter. And certainly living in New England here, we've had a tough winter weather, and looking forward to some summer here with the weather getting nicer soon. So I love technology as well. So I do spend a good amount of time with helping to kind of program different tools for our patients to be able to utilize, like meal plan generators and so forth. And of course, spending time with family and friends. So
great.
That's my types of hobbies that I try to do outside of work. But luckily, I love what I do. So it makes my job rewarding in a sense too.
Amazing. And Joe, what's the one thing that you would like to highlight of Salem, New Hampshire for potential visitors? I've never been there yet.
Yeah. This area is nice in the sense that it is more suburban, it's quieter, but it still has, aspects of a city life where we're only about 35 minutes away from Boston. We're only about 40 minutes away from the beach. And we're, about 30 minutes south of Manchester, which is more of a city-like atmosphere in New Hampshire. So it's nice to have access to all the exciting things happening in Boston and Boston sports, but also have beach access and a bit more of the beautiful foliage. So I would say anyone in the fall season coming up to New Hampshire to see the autumn leaves change color is certainly a beautiful thing.
Great. Joe, before we wrap up, how can listeners get a hold of you with any questions?
Sure. I do post a lot of content on LinkedIn regarding obesity medicine. So you can follow me on LinkedIn, just Joseph Zucchi. You can find me on there. Also, for anyone that is in the area here, you can find me and my office, Transition Medical Weight Loss, here in Salem, New Hampshire. Our website's transitionsalem.com. We do serve patients, like I said, in New Hampshire and Massachusetts, both in person and virtually. And so, happy to connect. I'm on the board of the New England Obesity Society. We often do webinars for providers. There is a really excellent Facebook group called Evidence-Based Obesity Medicine Practices that has about 10,000 members in it. And I'm one of the moderators there. We post a lot of content about webinars and free topics and education opportunities for anyone working in obesity medicine, or even primary care providers that are dealing with obesity medicine in their practice as well. So continuing to try to just educate people and get the word out there when any of these new updates come out, because there's a lot of them.
Wonderful. Thank you so much, Joe, for your time and being a guest on MD Roundtable. Keep doing the great work you're doing for your patients at the Transition Weight Loss Clinic. Thank you again for your time, Joe.
Thank you so much. Pleasure to be on here, and hope this was helpful for people to learn more about it. And for any patients out there that are listening that are struggling with their weight, I hope you hopefully hear my optimism in terms of more options than ever before. And always note that, this is never your fault, that you deserve care and compassion with your treatment plan. So find a provider that can work with you to help you achieve that.
Awesome. Thank you, Joe.
Thank you.
Folks, if you enjoyed that episode, don't forget to leave a review of MD Roundtable podcast, and don't forget to subscribe. Also, if you want to reach out to me with any comments or questions, feel free to go ahead and email me at drtedthatchandcarey@gmail.com. Once again, drtedthatchandcarey@gmail.com. I will also leave the email contact in my show notes. Thank you again for joining me. Have a great day.